Brilliant, thank you. So we'll begin now, and as I said, the recording will be available. So my name is Nikki, and thank you for joining us today, and hopefully we'll stick to times, but I'll also give you an opportunity to ask questions during or at the end of this session. Just use the raise your hand function. So if you go to the next slide. So we're currently under a consultation process, but what that means is we used to previously be 7 place spaces, 7 boroughs, City, Hackney, Tower Hamlets, Newham, Waltham Forest and BHR. We have now come collectively as one single NEL ICB, and the reason for this was actually just to reduce inequalities and variances across NEL. And that's one of the reasons we formed PCNs quite a few years ago now, is to reduce those health inequalities. That doesn't mean that we won't, understand borough priority. So hence you'll still have currently a senior prescribing advisor and a lead pharmacist that will support individual boroughs and PCNs. But that's currently where we are. Our 3 place spaces, so City and Hackney, BHR, which is Barking, Havering and Redbridge, Tower Hamlets, Newham and Waltham Forest are all coming together singly. So all acute trust, collaborative trusts will try and work together to reduce those variances, but please be assured that you'll still have a lead pharmacist and a supporting advisor to help you with your local initiatives and queries. And this is how the structure currently looks like. Next slide, please. So the role and vision of the Pharmacy and Medicines Optimisation team. So we want to embed 4 key functions and core functionality. So part one, if I look at, is medicines commissioning, local formulary review, shared care pathways, access to guidelines and services. We're sort of supporting and contributing towards how we commission local services. The second aspect of this is looking at the medicines and the finance side of things. So that covers the prescribing budgets, cost pressures, supporting with quality improvement projects, so QIP, so high cost drugs and therapeutic areas, how we can sort of making sure this is cost effective on the taxpayers' monies, but also making sure we're getting the best health outcomes for our local population. The third aspect of our core team is to look at medicine safety and quality, and there is a slide that will go into this functionality a little bit more in detail towards this presentation. In this aspect, we look at the clinical governance side of things, MHRA and CAS alert, antimicrobial stewardship, so looking at local and national campaigns and priorities, implementation of NICE and evidence-based guidelines, clinical governance around non-medical prescribers, and that's where pharmacists fall into this remit as well. And then the fourth side of it, collaboration and coordination and support, includes how we embed all of this, how we support our clinicians in primary care with education and training, leadership, looking at sort of medicine shortage supplies and all medicines related queries and so forth. Next slide, please. So going back to queries, we do have a generic local inbox available. So we recommend that clinicians can use this, sending an email from your nhs.net mail. Currently, this is our North East London ICB T&W generic email. We are in the process of sort of moving this towards a single NEL generic email, and when that's up and running, we'll give you the relevant communications. What we always emphasise is when you're sending us queries or information, do not include any patient identifiable information, as we're not allowed to have access to this information governance and so forth. We've had a few surgeries in the past that's also used Accurex, and that actually we recommend you do not do this because that gives us patient information, and that's what we're trying to avoid. When you do send queries, try and include as much information as possible, so which trust is it, where the request has come from and so forth, and to allow up to 3 working days to receive a response. There are lots of, so if we move on to the next slide. Thank you. Often we do receive queries about, you've had a request from a specialist or a therapeutic area from secondary care, and you've got to try and understand that we do try and empower our clinicians in primary care, from GPs to pharmacists to dietitians, to have the most up-to-date information on our local portals, and we also like the EBNF, Script Switch, Optimise, There's lots of information there, so we always try and sort of equip you with lots of tools available, because we don't have as much patient information, we don't have the full history or access to bloods and so forth. We're really trying to encourage our pharmacists especially to build those stakeholder relationships with the specialist, and actually getting information directly with the secretary, advice and guidance, and discuss this in your team meetings, because often your lead GP would be able to support this, and you'll be able to get clarity because you've got the patient information in front of you. Where we're here to support with queries is often if it's sort of something that's brand new, or there's a nice TA, or a new pathway that's coming about, or complex query. That's where we can try and support, and if we need to escalate decisions and take it to our medicine safety group or IMOC, which is where, or formulary and pathways groups, we can bring it to their attention. So in the first instance, what I really want to do is empower our pharmacists who are working in primary care to use the portals. Often the latest guidelines, shared care documents, transfer of care documents, and the formulary will guide you to make some decisions, and often it will be looking at the holistic picture to try and come to a decision for your patients. Unfortunately, the ultimate decision will remain with the prescriber. These are our portals. So Tower Hamlets, currently you've got to log in through Clarity or TeamNet. Newham and Waltham Forest are currently sharing a portal, and that's the link over there. So my biggest ask from here would be actually just make sure you either save this on your desktop and you're able to familiarise yourself and navigate yourself on this portal. If you've got queries about the portal, by all means send us an email or get in touch with us at the end of this, and we can try and assist you with this. Next slide, please. So I get GPs and pharmacists asking where certain things are kept. So my biggest takeaway from here today actually will be just please go on these portals and familiarise yourself with the content and see how helpful you find this. We are also in the process of merging this as a now ICB webpage. Once this is under development, you will get the relevant communications when this is up and running successfully. And again, we can give you some training on this. But in the meantime, this is what we've currently got available for our local boroughs. So Newham and Waltham Forest, we're hosting it on one single page. Again, this is where the formulary complete is for Newham and Waltham Forest. Just make sure you're familiar with how to access the EBNF on our current formulary. And Tower Hamlets, you use a slightly different link that takes you to the formulary complete. I can see there's a question from Fahana about when it's going to separate from Newham to Waltham Forest. It's probably not going to separate. Like I said, we're becoming now, so all our guidelines and formulary statuses eventually will become a single formulary, and it will be hosted on the now ICB page. So it might have some local variances which would highlight, but from my information, it wouldn't be separate. We're trying to reduce the
I don't know. There's no good restaurants in Hornchurch.
What about Rasa? We can go there.
But he said don't go too far.
Denisha, can you mute yourself, please? Thank you. Yeah, so I don't know if I've answered your question fully, Farhan. I've just quickly had a look at that question that came up in the chat. It was to reduce variances, but if there will be local discrepancies, we would highlight that. But at the moment, there isn't. We're not planning to separate Waltham Forest from Newham. As I said, it's going to be one big now ICB page. This is the Tower Hamlets formula complete, formula status. I'm under the impression that the key is currently not working. Am I correct, Eric?
So yeah, on the Tower Hamlets formulary page, the key link is not working. However, the formulary status for the keys are the same across TNW anyway.
Yep, perfect. So again, navigate your way through the site. That would be really, really helpful. And if you've got any specific questions, then we can definitely try and assist there if there's any technical problems and so forth. Just with the AMBER, I think in Newham and Waltham Forest, there's two slightly different keys. So there's one that's specialist initiated with no shared care, and there is another AMBER which is specialist initiated, requires a shared care document. So just be aware of that as well, please. Next slide. So again, this is just about making sure you're familiar with it. Lots of our contents are on there. So for example, the now antimicrobial guidelines that were actually updated and tweaked in March, that's all up to date under prescribing guidance, and you'd find it under the relevant chapter. Shared care guidelines from different acute trusts, or that's all there basically. So again, please let us know if there's any concerns, but just work your way through that kindly.
Yeah,
next slide.
To update with there's a shared care working group that's under the formulary and pathway group as well, which is looking at creating shared cares that is for the whole NEL rather than individual borough. So I think the group is looking at adopting the national share care guidance as well. So again, like once we have any updated share care guidelines, we'll share with you guys via comms and also upload onto the portal.
Thank you. Now, so as I mentioned earlier, the pharmacy and medicines optimization team sitting within the ICB has some core functionalities and roles to deliver, and one of them falls under the NEL formulary and pathways group. It's actually quite a big it's quite a big committee, quite a big working group, and that's one of our key roles, to making sure there's pathways, access to services, medication. So this particular group looks at that, new drug applications, implementing new NICE TAs, ratifying the position and so forth, local medicines pathways. This is more just an FYI of some of the things and the systems, working groups that we have within the ICB and within our team. And if there's any new comms or new pathways that have been developed, we will share that in a bulletin with you or by separate communication. Once we've, you'll start to see shortly in the next few months sort of NEL-wide training hubs and things for any specific guidelines and things like that. So I know we've launched respiratory guidelines, but the plan is when we launch, for instance, oral nutritional supplements or the adult ONS guidelines, we'll try and get together through the NEL training hub training sessions to implement this and get that message across so that everyone's kept in the loop. So this is just one area of an example of a working group currently that's taking place across our group team. Yep, next slide, please. This is another area, another big working group, the NEL Medicine Safety and Quality Group. But I mean, this is just, again, an FYI for the pharmacists and for clinicians in primary care, but this is some of the work behind the scenes. And we've put that in there more just for you to understand some of the work areas that we are supporting with and deliver. But how you can in primary care sort of incorporate this is by looking at your high-risk drug monitoring processes, opioid prescribing, deprescribing, and again, just to sort of emphasise any incidents and managing risks in your day-to-day role is how can you do this. So, for example, reporting incidents on the national portal is quite important. Looking at CQC reports, looking at utilising Eclipse and so forth. We've incorporated this into our larger role, but how you can do this on a day-to-day basis. Some of these things are highlighted below in that list. Next slide, please.
Thank you. I'm just going to take over from there.
You'll take over.
I'm just quickly going to go through you guys in terms of the data that we uploaded onto the individual portals. I hope you all have seen and know where the data are. So basically, the medicine optimization team, we upload all the listed data right here onto the portal on a monthly basis. And I think for Tower Hamlets, New and Waltham Forest, they are all divided into PCN and then subdivided into practice level. So you can actually see the relevant prescribing activities for your practice individually. So in terms of where the data are, it's very easy. This is the Tower Hamlet portal. Basically, just click into the MOS resources and then click into the MOS data. That will prompt you into the data page that is divided into PCN level. And then once you click into it, it will subdivide it into whether it's in MOS data, hospital only, or special prescribing. So if you work in Tower Hamlet, please make sure you've got access to this portal and also know where these web pages are. As the new MOS scheme is coming up over the next few months, we will create a new page for that. So just make sure you have a look out. In terms of New and Waltham Forest, I think as my colleague mentioned, they are hosted in the same portal. However, it's just because the portal are public domain, so that's why you will require a login for that. The login is generic for the practices in Newham, so please make sure you take notes right now if you work in any new PCN practices in order to access these data. And this will be the logins and the locations for the Waltham Forest portal. Great. So I will just kind of give you like a quick look in terms of how the data presented. So basically, using MOS as an example, majority of the indicator, we actually use the prescribed ones. That's why this is how the prescript presents to you in terms of your prescribing. And just do bear in mind that these data are actually presented on a monthly level. I know that for the last financial year, the MOS is based on the comparison to the baseline data that is in Q4. So in order to calculate it, we will just actually average out the 3 monthly data just to find out how's the performance compared to the quarter data. And obviously the RAC rating is based on the prescribed indicator as well, which is the MOS also follow from last financial year, so just be aware. That's one thing I want to highlight, that quite a few practices actually emailed over and asked for it in terms of the most up-to-date data. So basically the prescribing data, first of all, they normally processed by NHS BSA. That's always 1 month delay from that. And then Prescript will further analyze that data. So it's subdivided into different categories. So that would take another 6 to 8 weeks delay for the processing. So in order for us to be able to obtain the data, we will be 3 months behind when we upload it on the portal. So I know that our data analyst has just been managed to process the February data, which has just been released by Prescript and NHS BSA 2 to 4 weeks ago. So we will be uploading the February data onto the portal right now, and that will be the most current up-to-date data, which you can have a quick look at. So this is just one example in terms of how the spreadsheets look like when you download the specials and hospital-only prescribing data. I hope you guys are all aware in terms of the specialist prescribing and general principles. It's always preferred to use the licensed version first. However, if there's a particular clinical need, then yes, you can prescribe specials, provided there's a document right there in the patient's clinical record. However, what this spreadsheet and data allows you to do is actually quickly run a search on your EMS or System 1 program, and then to identify the patients who are on these specials. Just make sure they're reviewed regularly, and also to assess like whether do they need to be on these medications regularly. Same logic as hospital only medications. Remember, it's been agreed with Bath Health Trust, our local acute trust provider, that these medications should only be prescribed by the specialist rather than in the primary care setting. The reason why is just we want to protect our primary care colleagues, and obviously to have a clear responsibility and know where they are at in terms of when prescribing these medications. So if you notice patients are on a hospital-only medications that you are prescribing at the moment, please have a quick look in terms of the documentations from the patient's record. And if you think it's appropriate, perhaps to contact with the initiating specialist or the team, just to liaise with them to see whether would they be able to take over the prescribing back in the hospital settings. Again, if you need any support, the team right here is actually to facilitate the communications between you and the hospital team. So please do send us an email if needed. So again, the medicine of low value data and self-care products is according to Prescript analysis. It will continue to be on the portal page. It's just because these are all the national agenda, so that's why we kind of have to, we will have to publish it for your information only, but also we strongly encourage you to review these data and to promote that these medications should not be routinely prescribed according to the national guidance. So Script Suite, I hope you guys are well aware of that. Is a kind of messaging system that's already embedded into your clinical system, EMIS and System 1. What it does, it prompts for cost-effective and clinical effective prescribing. We also, one of the examples for the MOS one that we use is actually prompting the salbutamol to prescribe Salamol instead because of the carbon footprint. So just do bear in mind that these messaging system, we also have some messages that will support you to implement the medicine optimization scheme. And in terms of cost saving profile, it's sent to the practice on a monthly basis. So if you don't receive it, please speak to your practice manager and to see where the relevant cost saving can be. Just a very quick update in terms of script switch. So recently, it's fairly recently that the now ICB has actually adopted the optimized RX rather than script switch. So I think there's going to be a phasing out process over the next 3 to 6 months. However, there will be official comms that will be communicated to primary care very soon. Optimize RX and script switch they work very similarly. So I'm sure there will be supporting materials in terms of how to use the optimized RX in your practice. And just to watch out for the communications being sent from us. Eclipse Live is a risk stratifications tool that will actually help, that will go through the clinical records in your system to highlight patients who are actually at risk of the hospital admissions. It will classify it in red and amber alerts. And just to let you know that the Eclipse, that company actually download the data from your system every week. So it will be refreshed every Monday or Tuesday, if I remember correctly. So make sure that you, as a PCN or practice pharmacist, will be able to have allocated time to review these patients. It's just because these patients are actually at high risk of hospital admissions. And also, it is part of the medicine safety as well element. And it will be most likely to be incorporated into the medicine optimization scheme as well, is to encourage practices to start using Eclipse Live as part of their medicines risk identification tool. So if you haven't got Eclipse logins, please speak to your practice manager and then to contact us like subsequently, because you do need to have individual login per practices. And the other thing I was going to say, particularly for Tower Hamlet practices, Eclipse Live Auto implementation, which is the auto download from the practices, it has to be enabled for your practice. So please speak to your practice manager whether do they still need to upload the data on a weekly basis. If so, please contact us, because we will need you to sign the documentation form, which provide authorizations for Eclipse Live to automatically download the data from your practice rather than having to upload the data manually. This will also apply to Newham and Wolfram Forest practices, just in case. But speak to your practice manager to see whether they have to upload on a weekly basis. If they do, please do get in touch with the medicine optimization team, and then we will put in touch with the Eclipse Live team to set up. On the side notes right there, Eclipse Live actually got modules about the CQC preparations and also IF module as well to see where the performance of your practice is at the moment. So please make sure you utilize these modules, which is particularly for high-risk drug monitoring, as Nikki mentioned. It is part of the medicine safety element that PCN and practice pharmacists could play in their daily practice. And also it is one area that CQC will particularly look out for patients on high-risk drugs. They're going to keep.
Thanks, Eric. So this just brings us back to some of the resources that we frequently encourage our clinicians to be familiar with, and often the medicines optimization team will use webinars and bulletins and updates from Prescript ourselves. We get some of our data from here, as well as look at some of the clinical webinars and masterclasses. So it's free for all NHS workers in primary care. So do take the time out, just as a quick login. It just asks you to put your organisation, your sort of who you are really, and you'll get access to various webinars and masterclasses. We often in our monthly bulletin try to include what's coming up or what might have retrospectively taken place that might help you in your area of prescribing or in primary care. So just do take some time out to go onto here, and often it will just sort of you can help towards CPDs and so forth. Next slide.
Yeah, that's the next slide.
Oh, okay, thank you. Yeah, so just make sure there is a virtual induction here as well, so you can click on these links. These slides will be made available, or at least the links will be. But again, just look back at some of the historical bulletins that we've given, because that will have the webinars that already taken place or upcoming webinars. Next page, please.
Just to highlight that when you register on Prescript, please make sure you select the right organization rather than individual practice, because that will not give you full access in terms of material on Prescript. So make sure you select NHS North East London when you register with Prescript.
Thanks. Medicines shortage. So this is the live tool that is the Department of Health and Social Care have actually utilised the SPS website to give the most live up to date sort of timeframes on when drugs are coming in and out of shortages or anticipatory stock chain supply. So this was especially useful during the strep A peak that we had in December. So again, if there's any, obviously different practices will have different urgencies or different patients on different drugs. So it is useful to, again, sign up to this website and have access to knowing when something might be coming into stock. You might find that the primary care team, so it's a primary care team from the ICB that sends out emails to practices, usually a practice manager or the lead GP, but you might want to check with your practice manager if you're getting these alerts, and just making sure you have a process in place to identify patients that might be affected by these shortages. In the case where you are, this is really helpful, this particular tool, because it will help you anticipate when and how to manage your patient accordingly. For example, if there's an HRT that's come into shortage and you've already issued a 6-month supply in January, but the shortage is only expected to remain in place till May, you may not need to act on it and alert the patient. But in the case where you do, so it's just about giving you that ability to be quite proactive in how you manage such patients. It's quite live, and we recommend that you take a look at this from time to time or have a process in place for that. Again, on the SPS website, there's other tools and resources. A lot of MI queries can be answered through here by having taken the time out to looking at certain patient groups like lactations, pregnancy, and often there is a regional MI number as well that you can contact, and they often will ask for more patient details to get you a more sort of comprehensive answer and support your query as well. So that's quite a useful tool and resource to be familiar with. Next page.
Yeah, just to highlight that in terms of SPS website access, you do need to have the account by yourself. So please make sure you register with the SPS website if you haven't got an account yet.
Thank you. So prescribing visits to PCN. So we did this last year, sort of towards the late summer, and then we also got in touch with you towards Q4, just to sort of give you an update of how things are going and what to review and submit to the team. As you know, this year, the final methods optimization scheme is under development, as Eric said. So we're just finalising for members their feedback, and it'll be ratified by the IMOC group. That's the Integrated Medicines Optimisation Committee. So once this is all finalised, we will be arranging meetings with the PCNs and with the practices to come together just to give you an overview of the scheme. It is compulsory, it's mandatory for the first visit to take place as part of the medicines optimization scheme or prescribing quality scheme. So just be aware of this. The final sort of indicators are being finalised at the moment, but we will give you an update once that has been finalised. As Eric mentioned, the most likely host will be the portals, or if the ICB page is up and running, data will be available there. Be aware of the lag times, as we've already kindly mentioned. And we'll also, in these visits, give you an overview of any pilots or projects taking place across Nell or within our place, which is Tower Hamlets, Newham, and Waltham Forest. But just the main takeaway message from this is that a prescribing visit at PCN level will be a mandatory requirement as part of the scheme for this year's scheme, so to speak. Next slide.
Yeah, so just going to quickly go over in terms of the non-medical prescribing registrations. So for those who are new to the patch and recently obtained the independent prescribing qualifications, congratulations on that. So if you need to prescribe within your practice, you do need to register with NHS VSA to obtain a prescribing cost code that associates to your prescribing and align to your practices. So in order to do that, you would actually have to submit us several forms, but also complete the competency checklist with your prescribing lead and also your practice manager as well. So I would strongly encourage you to have a look in terms of the non-medical prescribing registration policy, because the appendixes are the forms that you are required to submit to us, and then we will go through that individually and then to submit to NHS BSA. And also just to let you know that you will have to, especially for PCN pharmacists, you will have to list out all the practices that you will be prescribing at. It's just to make sure that we will have this code set up appropriately and according to the practice you're prescribing under. Again, the process, it takes around 2 to 4 weeks. It's because like we have to individually vet this form. At the same time, NHS BSA, it does take time to come back to us in terms of when it's been successfully registered. In terms of the prescribing code, we have got a lot of queries that's been asked. Most of the time, the prescriber code will be your professional registration number. So it could be your GPXC number, but also or NMC registrations. However, we will send you an email and to let you know what the prescribing code will be once we have received confirmation from NHS BSA. In terms of setting the prescribing functions and profile on eBusiness System 1, unfortunately, we can't support you on that. This will be something that you will need to liaise with your practice manager in terms of how to do that. There are actually a lot of resources available online in terms of setting the prescribing profile on eMedicine System 1. So please have a quick look as well if your practice manager does not aware on how to do that. So over the past 3 months, there has been significant development in terms of the community pharmacy aspect of it. So the NHS England has actually provided funding for each of the ICB to nominated a person to be the community pharmacy integration clinical lead. So the essential role of this person is to kind of further develop and enhance the community pharmacy services to see how it can support and embed it into the PCN system. So in Northeast London, we actually have nominated 2 people, and they're sharing a job, which is Rita Shah and also Yogi. And again, just to let you know that this role is responsible across the whole Northeast London, and to see how we can optimize the community pharmacy services to support primary care and to reduce the workload. So one of the, well, there's 2 great examples right here. I think back in last year, March and April, we have successfully launched using the EMS local service, or known as Farm Outcome, for practices to refer community pharmacy for minor illnesses services. And at the same time, these services will also accept referral from NHS 111 out of hours as well. If you don't know how the process works within your practice, please do speak to your practice manager. And there were also training webinars that's ongoing basis being advertised on regularly in terms of how to use the CPCS referral and in terms of the referral criteria. The other services that is kind of fairly recently launched and gone live is the community pharmacy blood pressure check services. So this is a service where the community pharmacy will be able to do blood pressure check for your patients, provided there is a referral from your practice with appropriate clinical rationale. And do be aware that they will be able to support you the 24 hours ABPM service as well. However, just to highlight that each pharmacy has been only allocated for 1 24 hours ABPM machine. So there can be a bit of wait right there. What we encourage you to do is to speak to patients' preferred pharmacy and to see how arrangement that is. And also, please do not send all the referrals in one go, but to stagger it slowly, just to allow time for community pharmacy to process. Just for audit trail purposes, we strongly encourage you to do the referral via the EMIS local service, same as the one that you've been using for CPCS. It's just because this is for audit trail to make sure that because once the referral has been sent from the GP to community pharmacy, you'll be able to check whether has there been actions and just to make sure you can do the follow-up. because what we have noticed is that a lot of practices are doing referral by email, which can be lost sometimes, and also some practices are only referring to the pharmacy by a piece of paper, which again can be lost easily. So please make sure that you will send a referral via the local email service, and the responses from the community pharmacy will be communicated back to you via the NHS email. They're going to keep.
Thanks, Eric. So this just comes back to our local Tower Hamlets, Newham and Waltham Forest bulletin. We've been doing this quite consistently, been publishing a bulletin every month, and this is really, really important. I hope it's archived somewhere in practice. It usually goes to everyone that's on our mailing list, all clinical pharmacists, possibly the lead GP and practice manager as well. So just please disseminate this within your team. It's great to look back at it historically as well. So it will give you, for example, when the asthma or COPD respiratory guidelines were launched, it will tell you when, and the hyperlink to the portals. It gives you, as I said, about press script, webinars up and coming, and all local pathways, CPCS, webinars, and anything that we've covered that we felt is key over the previous month. This will be May's bulletin release will be the last one locally done. We are from June hoping to present and disseminate information for NEL guidelines and NEL medicines newsletter. So please watch out for that. And then we haven't thought of the layout yet, but it'll be very similar. All local content, pathways, formularies, and up and coming webinars will all be highlighted on this particular bulletin. So as it says there, from June 2023, please keep a lookout in your mailbox for the NEL-wide bulletin, which will be quite helpful as well. Next slide, please. So coming back to sort of local place-based schemes, we are trying to align it to NEL. So even when we do sort of work towards a bigger system, some of this is it's going to be harmonised across North East London, but some of the big focuses around our local area. So one of the things, for example, in Newham is about the dressings optimisation scheme. So in Newham and Tower Hamlets, we currently use Accelerate Click, and they're experts in wound care, and it's an online tool. If you have to click on this link when you get the slideshow, but again, in previous bulletins, we've put we signposted clinicians to this particular website. We're encouraging all practices to order dressings and wound management products through this particular online tool. Accelerate Click can source dressings much more cost effectively, promptly, and it reduces waste. And the savings that we will sort of acquire through this can be used towards transformation of services, particularly for wound care or in other areas. So we've had practice nurse meetings, practice manager forum meetings, and we've tried to sort of support our pharmacists to make sure that you sort of spread this message to your nurses or your clinical teams to ensure that everyone in the surgery or healthcare professionals that are seeing patients with regards to wound management have access to Click. It's very, very straightforward. If anybody in the practice is not currently using Click, or if you're aware that your practice does not have this system, please let myself know, and I can put you in touch with Accelerate, who will sort out logins for you quite quickly. Once again, we are monitoring data to see where the biggest sort of expenditure, which practice is doing this, because we can source dressings much more effectively. In Waltham Forest, it's managed a little bit differently. Your complex wounds managed by the Community Health Service by NELFT. There is a limited dressings formula available that you can prescribe by FP10, but again, we are looking to harmonise this with the rest of the boroughs, so Tower Hamlets and Newham and across NEL. Again, when that's up and running, we will give you the relative communications. My takeaway message would be, if you're not using Accelerate Click, or this is new to you, please do put your hands up or contact me individually afterwards where I can support, because we are looking at data and we're hoping to see an 80% reduction in the next couple of months. I can see a hand raised. Do you want to share something with me, Tabor? Yep, you're on mute, I think.
It was just to say I'm not registered. So
okay, just let me know which practice you're at. I'll make a note of this. Do you want to just tell me now verbally?
Yep, Wapping group practice.
Sorry, Waltham group practice.
No, Wapping.
Wapping, and that's Tower Hamlets?
Yeah.
Okay, Tower Hamlets is actually doing quite well, and the service has been it's been running for about 10 years plus, but I will look into that if yourself or anyone maybe your nurse does. So I think your nurse might be doing a lot of the prescribing, because general data shows for Tower Hamlets they're using the system, but it's great to know. And if you do want the system, or if you want to have a login in the absence of staff like nurses, just to be proactive, I can put you in touch with Accelerate. But I'll make a note of that. Thank you for letting me know. But generally, Tower Hamlets and your practice should be doing quite well. Thank you. And if anyone else hasn't, please register E16. Yeah, that's great. I'll make a note of that as well. If you guys can just make a note of that for me. Thank you. Next slide. So just general top tips for new starters, but also existing staff that are currently working as PCN practice pharmacists, or if you're employed directly through the Federation or through the practices. Just things how you might want to reflect on how to develop your role in general practice. So just, consider what your scope of practice and experience is. Have regular conversations with your lead GP or your mentor or supervisor. If you're new, this is more sort of if you're new to the role, is meeting with key practice staff, such as your practice managers, GP leads, or your lead pharmacists, to making sure you're getting the relevant communications at the ICB, whether it's ourselves, our MO team, or the primary care team. You're getting those communications bulletins, drug shortage notifications. Where we can, we'll facilitate this as well by adding you to our mailing list. But for new starters or people who are not so familiar with practice of primary care, just making sure you've had in-house training on how to run searches on EMIS or System 1. The appropriate use of clinical templates will, ensure that when you're doing medication reviews with your patients, you're covering everything. When you're doing asthma reviews, everything is being sort of ticked off and everything is covered in detail. Things, sort of top tips to look out for to improve your prescribing. And as pharmacists, what can you really showcase is, having a look at existing prescribing policies. Is it being adhered to? Is it outdated? We have some templates online, but it's things about where can you really make a difference in your day-to-day role. Again, have a look at ongoing training and CPD needs. Some of the resources we've mentioned will help support this, and you can work in partnership with your GP leads to support you sort of develop your role further, and just to ensure you know where the boundaries are and what your expertise is and how you can help sort of fulfill day-to-day medicines optimization. So some of our core functionalities, how can you encompass that in your day-to-day role? Next slide, please. Coming back to our key priorities and how you can support us achieve this. So one of the big things, another part of our medicine safety group, but also the now ICB vision in line with the current government priorities about antimicrobial stewardships and the NHS outcomes of framework. The two indicators at all primary care sort of things that we look at across the country is the total volume of antimicrobial prescribing and the ratio of broad spectrum antimicrobial prescribing. This data has previously, and it probably will form part of the medicines optimization scheme and prescribing quality scheme. Data is available on the portal, and also I've put this particular website on that talks about why it's so important and why it's incorporated year in, year out. So there's a 5-year national action plan and also the 20-year vision. So just make sure you're familiar with that. You speak to locums, or you sort of in your practice meetings, you're confident to be able to talk about why it's so important. We did launch the World Antimicrobial Awareness Week back in November, but what we tried to sort of really push for to all clinicians is it shouldn't just be a winter project or a week project. It's something that will take place across the year. So just make sure you're really confident knowing where the resources are and how you can possibly support with audits, or if you look at your data, if you're an outlier, what's causing this, or come to the root cause analysis of this and support your clinicians with this. So that's some of the priorities that we're working on, and where as pharmacists you can really support your GPs and the practice improve on this if it needs to be improved or sustain or maintain where you are. Next slide. I've already mentioned dressing, so I won't go into that too much. We've made a note of patients and practices who are not signed up, but please try to use Click where possible to make savings and to ensure the right dressings are delivered to the right patients, and Accelerate our wound care experts. Next slide. Oh, and just coming back to this particular slide, we often get, we sent out a memo in January, and I think we've put it in the bulletin as well. And this is why I always say sort of go back to the bulletin, because often key communications are made or have been made in here. Fresenius Kabi is our third party provider for certain ONS, so oral nutritional products, or for adults and home or tube fed patients. Now, our tube fed patients, some of them are some of our most vulnerable patients who rely solely on these products or partially to meet their hydration and nutritional needs. we've highlighted, I'm not going to go through the steps step by step, but there was a memo that was highlighted to show that when you receive a prescription request, the first thing that Fresenius Kabi does, FK, they will send you an email 2 weeks before the patient is due for their feeds. I'm still getting feedback from dietitians or the company that they've sent a prescription along and it hasn't been actioned. And then a second prescription reminder goes out to the surgery. And again, sometimes this is ignored. And then on the third attempt, they'll try to phone the practice. But as you can imagine, it's quite difficult going through to reception and to be getting that phone call in the first place. So what I'd say is pharmacists, can you please brief your admin team or your prescription clerk to make sure they know what email to look out for and how to action it before, ideally within the first couple of days, so that there's no delays in receiving the items that the company have ordered for these patients. Again, if you need any specific queries about this, or this is a brand new concept to anyone, please do reach out to me. I'll be more than happy to guide you through the process or resend the memo that we've distributed previously. But what we can't have is requests being made by FK and it's just being ignored because the staff turnovers or admin's not familiar with it. So please just engage with the wider clinical team in practices. Next slide.
Yeah, I'm just going to quickly run through that. So
yeah.
As Nikki mentioned it earlier, that part of the practice visit, we do let you know in terms of what's the current pilot and project that's going on across the whole now. So I just want to share one of the very recent one that's around opioid prescribing, which is one of the hot topic and is also part of the National Medicines Safety Agenda. So we did seek in terms of expression of interest from practices who are keen to deliver the patients group education sessions for patients who are on opioids for chronic non-cancer pain. And then this is a collaborative work with UCLP partnerships. And then basically we have created all the resources, including email searches, patient invitation letter, the slide deck for the group education sessions, and then feedback questionnaires for practices or PCN to be delivered to their appropriate cohort with an aim to improve better understanding on the opioid use, but also at the same time, the chronic pain management. It is quite as in you do require a lot of staff and input to deliver these sessions. We are aware of that, and it is a lot of work to do it. However, out of Northeast London, we have a few practices that actually volunteer and express interest. And up to date, there's one practice in Havering who has successfully delivered 1 sessions to their cohort of patients, and the feedback was very positive. They were saying the patient attended are very engaged, and also they're very keen on sharing their story and their understanding about chronic pain, and also their mindset about opioid use. So that practice is actually going to deliver a few more sessions, and hopefully for those patients who attended these sessions will come back to have a review with the GP or the pharmacist to talk through their opioid prescribed, and then hopefully eventually will be wean off the opioid and then to use other non-pharmaceutical approach. So these are the projects that we will send out in the bulletins and in the communications that we will seek for expression of interest, but also some of the projects are expecting the PCN and practice pharmacist support to implement to make sure that in terms of the strategies that we will have the collaborative work and also support from you guys to be able to implement across now. So just to watch out of that, it is part of the expectations from PCN and practice pharmacists to support all these individual local work streams, etc. There you go, Nikki.
Right, so it's just a summary of some of the references and resources that we've highlighted through this, and some of it might be new or we haven't mentioned it, but it's worth just signing up for PressScript as a minimum SPS because they're really, really helpful. I'm sure lots of you are already signed up or faculty members for our Royal Pharmaceutical Society, and a few other resources such as Open Prescribing, and MedOptimize gives further data and resources as well. So that's just a bit of information there for you, current resources that we have available, including the CPEN Pharmacist Forum, GP Educational Forums, and there is a WhatsApp group for PCN clinical pharmacists and practice pharmacists. If you feel there's someone missing or a new starter, please do flag that to us and we can add them onto the group as well and onto our mailing list. This slides and this recording will be shared, so all of this will be available to you. I think we're coming towards the end of the slides, and this is just sort of a nutshell summary of what Eric's already mentioned, or what I may have mentioned. In-house general practice member staff, just making sure that so identify which practice are within your PCN. So we're really trying to push for collaborative working. This has been an ongoing focus for a few years now. We should all be quite established within our PCN roles and know who our neighbouring practice pharmacists are, as well as clinical directors, and ensure that you know what your priorities locally are. So as we are expanding to this NEL system or ICB, we really are encouraging you as a first step to reduce those variances, to work as a PCN and know each other and work in partnership really. Also work with your local community pharmacy providers. It's really helpful to have that relationship with your community pharmacist for a number of reasons. As you know, there's been many new services that have recently been launched, but also to support iron out any repeat prescribing issues or stock shortages. We're really encouraging collaborative working, and stakeholder engagement is really key to a practice pharmacist role. You can't be working in isolation, it just won't work. Patients won't receive optimum care. So it's really important as individuals and as practices, you working collaboratively with local stakeholders. And this sort of comes back to the confidence and being able to sort of pick up the phone, or using advice and guidance, emailing the secretary at the hospital in your acute care setting, just to be able to ensure that your patient's getting prompt sort of responses and you're able to address their concerns and support yourselves as well. With terms of sort of working community pharmacists, do feel free to invite them to your practice meetings if something's not working, but just really being proactive about that. That's it. Any questions? Yeah, if we can open it up. I know it's been quite quiet and a lot of content thrown at you. We do appreciate that, but please do feel free to ask any questions at this point.
Yes, so we still got around 8 minutes left.
Yeah.
Catherine and Manara, are there any questions in the chat that we need to address that's not been answered?
I think they have responded to a few. So a few of the, we will get back to them individually. Is there a guide on how to use A&G services? I think primary care might have put something out there for you, but often it's an email that you have an option on EMIS, and you can send out an email directly. If there is a full SOP, I will try to get hold of it and I'll get back to you. But otherwise, it is literally, you click on that EMIS button and you can just write your query and copy and paste some of the consultation to your specialist. Often you can actually pick up the phone or the secretary, and they're quite good at responding to queries.
We've got a hand raised.
Yeah. Hi, Mohammed.
Hi, I'm a NEOM lead clinical pharmacist covering Carpenters, Lucas and E16 Health.
Yeah.
Just when I spoke to one of the local community pharmacists last week, and I was requested to issue 28 days prescriptions. And what we are trying to do in practice, just to minimize the number of prescriptions, so we are aiming to get the prescription changed to 56. So is there any CCT or any guidelines you guys, or would you recommend 28 days or 56?
It would depend on the individual patient basis. Is it 28 days because it's a Dorset box, or is it just 20? No.
What they're trying to get the prescription number increase rather than 56. So.
Okay.
I think,
there isn't a local position on that. It would be looking at your, you've got to look at patient convenience. Is it convenient for that patient to go in every 28 days? If you're happy from the point that the patient's stable, their bloods are okay, it makes more sense work capacity wise for yourselves, for the patient, 56 days is safe, then, these are your reasons that you should explain to the pharmacist that we wouldn't be doing that. In some cases, 28 days is more efficient, but that's mainly based on clinical indicators, clinical safety. They've just been initiated on a spironolactone, for example, or new blood pressure medication. So it's really on a case-by-case basis, and that's what our formulary positions or our guidelines will always suggest. We don't have anything written, but that's what we'd recommend, is look at your patient as an individual and base your reasoning and case forward to the pharmacist for that reason. Does that make sense? So if your patient's stable,
yeah,
go back to the pharmacist and say it's probably more of an inconvenience for the patient to be coming back and forth. And we really want to look at patient. I mean, at the end of all of this, whether it's finances, safety, our patient is at the heart of what we do. So try and push for that and get them to understand that really.
It's just the
Thank you.
the
No, that's fine.
conversation with
Yeah.
community pharmacy and the PCNs, because
Sure.
as a heads up that this year we are heavily focused in terms of collaborative working within the PCNs, not only with other practices, but also expected to communicate effectively, work closely with your local community pharmacies. So just get a heads up right there that collaborative workings are heavily focused this year. So please do feel free to make a head start, and it's also like the ultimate point is actually beneficial for your practice, and also just to make life easier in terms of daily work life, because community pharmacy right there to support you. So yeah. We still got 4 minutes. Yeah, do we have any questions?
Another question, don't mind asking me. I usually see diabetic patient, and we come across private consultant requesting semaglutide from primary care GPs to prescribe for weight loss. I'm not sure. I've sent email to consultant MDT, which cover in our patch. I haven't got the response yet. Do we have tier 3 weight management program in CCG, new CCGs?
Don't do we? We're looking into this, but I don't think we do have a tier. We've just had a few queries. So these are sort of queries we really, really appreciate, and we are trying to escalate it and get an answer for you guys. At the moment, I'd say no, but the IMOP, the formulary and pathway groups, are looking into this at the moment. So with private consultants, you know, it comes down to that whole ethics and how you manage that. Do we refer into NHS? Yes, we do, but we haven't got a tier 3 at the moment, so we're looking into this pathway.
Thank you.
Yeah. I can see something about exceptionality reports. So as Eric explained earlier, we're still lagging data. Only February's been released just now. So in the next 6 weeks, we would expect March's to be released, and then our data analysis will gather this. So you can do it if you feel.
June. It's looking around between June and July.
June and July.
Send out the outcome.
Exactly, yeah. And we'll send out the comms then as well. Yeah. So I hope that answers that, Imran.
Does anyone have any things like that to share in terms of projects they're doing, in terms of their patch? Because we've got a very good turnout today. We've got 40 plus. So I think it's a very good platform right here as well for you guys to share learning in terms of common difficulty, etc. Feel free to raise your hand. Like it's a free platform. So in terms of the Imran, for your questions about the community pharmacy blood pressure check service, the participating pharmacy that delivering these service will be available on the local EMIS once you click onto it. And yes, for the pharmacy that are providing this service, they need to provide both clinical blood pressure check, but also at the same time 24 hours ABPM. So if you want to know which pharmacy nearby patients or nearby your practice is doing this service, just go onto the local EMIS service, and then it will sort out by the pharmacy with the closest distance. Great.
Thank you.
I can't see any more questions right here.
Optimize. We're receiving that. We're not commissioning this, so to say no, really, yeah.
Imran, would you mind just let us know a bit more information right there, because it's quite interesting that the third party service offering. Yeah, what is it about, Imran, if you don't mind? Okay.
Hello, can you hear me?
Yeah.
Hi, yeah, thank you so much. This has been happening quite a bit actually, with like representatives from, respiratory companies and things when it comes to mark prescribing, or for example, with diabetic test strips and things like that. So there is like a sort of confidentiality agreement that's involved where they'll be granted like temporary access to access patient records in order to, sort of do a data analysis and then come up with a report so that we can consider, switching patients onto what they obviously will say is more cost-effective brands. So when I had one gentleman come in one of the practices, I did refer him directly to the TMW team because I realized that there is a sort of wider range of selection of these things. So I was just wondering if you had any view or opinion on that, like, you know, how do we manage that?
Escalate it, actually, as Eric said.
So yeah, currently we, as North East London ICB, as far as I'm aware, we haven't commissioned any drug reps to go into individual practices in terms of providing service to review their record. In terms of working with these drugs rep, it will be entirely dependent on your practice and the agreement that you agree with, like with the drug reps. But the ICB has not commissioned any drug reps to go into any practices and to implement searches. So I will so within North East London, we historically have a working with pharmaceutical company policy. It's currently being being reviewed at the moment. But however, this will need to be down to your practice, because if your practice think that the drug rep input will be beneficial to your practice, and if you agree with that, then it will be the decisions from your practice. However, from North East London ICB, we have not commissioned any at all to go into practice to support their prescribing, if that makes sense.
That's really helpful, thank you. We actually had a meeting set up from one of our senior GPs and practice manager regarding ONS prescribing and auditing. Now, I was just sort of interested, you know, because Nikki just mentioned regarding the Fresenius being the sort of NEL-sponsored issuer of ONS. So I imagine that once this procedure is completed, if they're not from Fresenius KB, they may or may not decide to prescribe or advise to prescribe that item.
Can I just confirm, Imran, which company was it, FK, that came to you directly for ONS?
I was actually just having a look at it now. Can I just have a moment to
Yeah,
see if
sure.
I can open the email up?
But as Eric said, we haven't commissioned anyone. And if you think it's good for your practice, great, but always just make sure it is in line with the current. So for glucose, for example, diabetes stuff, North East London recently released some guidelines, you know, what our top lines are and so forth. Same with ONS. We're in the middle of updating our adult ONS products, so it should always still be in line with our local formula. If you're then getting a third party coming along, switching over to their preferred product, if it's not within what our local formulary is or what our guidelines is, just be really careful there. So it will be, and again, information governance and all of that to take into consideration.
Yeah, I can see that.
But yeah, I'm happy to, if you want to just reach, I can stay on a bit longer if you get that email up for me. But with ONS, it's being developed and we definitely haven't commissioned anyone to go into practice to do this. This is an area of portfolio I actually look after. And as I said, we're just developing those guidelines.
Brilliant. I'll just get back to you in a moment.
Yeah, sure.
That.
Yeah, I'll stay on at the end then, no problems.
Great. So we are 3 minutes past now. So
yeah.
If we haven't got any questions, we're just going to close the sessions. Nikki mentioned that it's being recorded. So what I'm going to do is I'm going to liaise with the training hub leads, and then we will circulate this to those attendants who attended today. As this training sessions is a reoccurring one, so it happens every 2 to 3 months. So the recordings will not be hosted on the portals, but we're happy to share the recordings for those who attended today. And also, yeah, just to let you know, the focus for today is to refresh and to give you a little bit more background information in terms of what our team does and to support you right there. Great. I am going to close the sessions. Catherine, if you can stop recording, that would be great.
Yeah, and any queries that we haven't answered or we need to get a little bit more information, we will get back to you. We've made a note of those queries and someone will respond from our team. Thank you. We're going to end the recording there. Yep.
Thank you for attending today, guys. Lovely seeing you all, and look forward to the emails.
Imran, do you want to separately email me?
Yeah, that'd be perfect.
Yeah, I don't want to rush you. Just send me, you can send that directly to me, but pretty much on what myself and Eric just said to you earlier. But thanks for bringing that to our attention. It's quite interesting. Yeah.
Amazing.